Good afternoon, everyone, and welcome to Topical Thursday. This afternoon, our special guest speaker is Marlou Tacouge, who will speak to us about the role of the exercise physiologist after stroke. Marlou is an exercise physiologist and team leader, and he is an accredited exercise physiologist. Marlou completed his Bachelor of Clinical Exercise Physiology at the University of New South Wales in 2013. He previously worked at NeuroMoves and spent over 3 years working with a range of neurological conditions, particularly in spinal cord injury, brain injury, multiple sclerosis and stroke. Marlou leads the development of the National Strength and Conditioning Service Program across all NeuroMoves sites in Australia. He has a strong passion for neurological rehabilitation and is determined to push the boundaries with his clients to maximise their recovery and quality of life. Marlou joined the multidisciplinary team at Advance Rehab Centre in February 2017 to continue to build on his clinical knowledge and skills. In July 2018, Marlou was given the opportunity to lead the exercise physiology team at Advanced Rehab Centre. He values the importance of building strong relationships amongst his colleagues and working together to ensure clients are provided with the best rehab outcomes and experience. It is my pleasure to welcome Marlou here this afternoon.
So today I'll be talking to you guys about the role of exercise physiology during stroke recovery, and I'll go through a bit of a rundown of what I'll be talking about. So what is an accredited exercise physiologist, the differences between EP and allied health professionals, the different stages of stroke rehab, the role of EP in a multidisciplinary team, the benefits of aerobic exercise in stroke, and lastly, the physical activity guidelines. So what is an exercise physiologist? So EPs are university qualified allied health professionals who specialises in the delivery of exercise and lifestyle programs for persons with a broad range of chronic conditions. So we like to think of ourselves as the experts in understanding the body's physiological response to exercise, and we use this knowledge to treat specific diseases or conditions such as stroke based on the evidence-based practice and research. So essentially EPs will use exercise as medicine to treat specific health outcomes in order to maximise an individual's functional capacity and their quality of life. So what are the differences between physio and EP? So I'll run you down what physiotherapy involves, and then I can compare that to EP. So physiotherapy, they provide a comprehensive therapy assessment and recommendation, and they can actually treat upon diagnosis. They're more of a focal and fine-tuned approach to therapy, and will focus primarily on your functional impairments or problems, and their goal is to assist you with things like skill acquisition and motor relearning. So these will include gait retraining and functional skills like walking, transfers, and bed mobility, and will also assist with prescribing any walking aids or equipment. So on the other side, we've got exercise physiology, and our role is purely based on the long-term and chronic care management of health, and would like to provide advice, support, and education around your health and how we can maximize your physical activity levels. We're more of a global approach to therapy in prevention and treatment of illness, such as cardiovascular diseases and other metabolic conditions, and we'll specifically use exercise to improve your aerobic fitness, your muscle strength, and a bit of balance as well. And then lastly, we also play a role in lifestyle modification and how we can get you back participating socially in the community. So to put it all together, physios and EP working together, both disciplines do overlap to a certain degree, but also do possess different knowledge, clinical skills, and experience to deliver appropriate services that is best practice for the individual when and where it is needed. So the key message is that both disciplines complement each other. Okay, so the next slide is a bit of it shows the stages of stroke rehab and where you can see the differences between the physio, OT, and EP involvement in an acute setting, subacute setting, and a chronic setting. So recovery and rehab can be divided into 3 stages, acute, subacute, and chronic. And throughout all stages, we can expect some degree of stroke recovery. So I'll briefly touch on each stage on stroke recovery and which disciplines are involved. So in the acute stages, this is where primarily a physio will be involved within the first 30 days in a dedicated stroke unit. And the goal is to stabilize the patient's condition and minimize the extent of damage. Rehab can begin as soon as the patient has been stabilized, but generally rehab will be more passive and more the prevention of secondary complications such as contractures, pressure sores, or deconditioning. In this subacute phase, you'll generally see a physio, OT, and sometimes there may be an EP involved during the stages of the first 1 to 6 months. So once stabilized, these patients are moved to an inpatient rehab ward where they will see a physio or OT and have a neurological assessment and set community discharge goals. The thing to highlight is that the first 6 months is the optimal window to take advantage of spontaneous recovery, which I'll talk to you a bit more about in the later slides. So the physio will focus more on spasticity management, range of motion, motor relearning, and compensatory strategies, where an OT will also focus on more on the upper limb therapy, home and community access, and equipment required at discharge. And then over into the chronic stages, there'll still be a physio and OT involved based on your goals, and this is where an EP will come in and help assist with the long-term care management of greater than 6 months, so they're post-discharge into the community, and generally we'll see our patients at home or at a private clinic in the clinic, and they'll be typically finished as an outpatient rehab and no longer engaged in any kind of structured physical activity or exercise once their rehab is complete. So by the time we do see them, they're still aerobically deconditioned based on the assessment tools that we use in terms of their weakness, reduced muscle mass, and also the development of secondary health conditions and the increased stroke risk factors for a recurring stroke. So hopefully that gives you a bit of an idea of the stages of stroke rehab. In the next slide is the role of EP in stroke rehab. So you can see there is some crossover within the scope of practice, but our main role with 6 months onwards is to establish a proper aerobic training program targeted at improving cardiovascular fitness and muscle endurance from the early subacute phase, so that first 6 months to maximize the benefits of spontaneous recovery and maximize the effects of neuroplasticity, particularly for motor relearning. I'll talk to you about neuroplasticity in the other slides as well. And then the next thing would be to establish a proper progressive resistance training program or strength program, because often in the early stages, the primary goals are to improve function alone. So things like learning to walk or standing up for the first time and progressing onto sit to stands. And you would practice this over and over until you've acquired that functional skill or task. So while this is important to practice, you would need to have the baseline strength required to begin with. And this is where an EP would be involved with a strength program to complement these functional tasks with the physiotherapist. Another thing to mention, I won't go into detail with this, is that specific exercise programs are used to improve the energy systems required for activities of daily living and functional tasks. And that's where we would come in to help monitor your energy levels and fatigue levels and work on those strategies behind that. And lastly, identify modifiable risk factors. So things like high blood pressure, which places blood vessels under chronic amount of stress, diabetes, obesity, and things like that to help minimize developing any kind of secondary health conditions. Okay, so this is what is our role of EPs in a multidisciplinary team. So towards the end of your kind of stroke recovery, once you're discharged out of hospital, MDT involvement in neurological rehab is still best practice. So again, the goals of therapy are still around restoring and optimizing your function for independence and increasing quality of life. But EPs are involved in improving aspects of body function that allow for your goals to be achieved. So we can do this by increasing fitness levels and muscle strength to optimize endurance and sustain high workloads. So again, what this means is that having the energy and ability to perform activities of daily living and domestic duties without fatiguing easily. So that can translate into walking longer distances, ability to perform functional tasks like washing the laundry, ironing, vacuuming, and gardening, and also increase social participation back into sport or other hobbies, or even being able to travel or return back to work. The second goal as EPs is to prevent, again, management of secondary health conditions such as obesity, diabetes, and cancer. And lastly, education of the importance of exercise throughout the lifespan. So EPs have a role in educating people to inflict long-term behaviour change and guide them in how to incorporate exercise throughout their lifespan, especially providing guidance and education on how to exercise when physical function changes, which is very common in a stroke population. And we do this by employing principles of like motivational interviewing and utilizing these models to assess people's level of self-efficacy, so their belief in themselves to change, their confidence, and where their motivation levels are. Okay, so the next slide, I kind of left a bit of the science and research in there. I wanted to speak particularly on aerobic exercise and the benefits of aerobic exercise on stroke, because that's particularly interesting. So it improves aerobic capacity, or VO2 max. So VO2 max is a measure of your cardiorespiratory fitness that an EP would use as an assessment tool. So in general, VO2 max is the maximum amount of oxygen transported from the lungs to the working muscles in a graded exercise test. So this is important because despite what stroke you had, stroke is a lack of oxygen supply to the brain, causing an infarct or an inadequate blood supply to the brain. So VO2 max is actually the best predictor for survival, and there is a direct association with life expectancy and the risk of developing a recurrent stroke. Another benefit of aerobic exercise is that it improves, or the total cerebral blood flow increases by 25 to 30% during exercise. So this is the blood supply again to the brain, and therefore bringing vital nutrients and removal of harmful waste. Aerobic exercise has been shown to decrease inflammation in the brain and into the central nervous system. The next point is that aerobic exercise increases BDNF and other neurotrophic factors. So BDNF, or brain-derived neurotrophic factor, is released after a bout of aerobic exercise, particularly at higher intensities. So BDNF is like fertilizer for the brain, allowing for motor relearning and firing regions of the brain that is responsible for movement. So at the correct intensity and dosage, aerobic exercise can promote a term called neurogenesis, which is the growth of new neuron connections formed in the brain. So this would be important for learning new motor skills or cognitive tasks for the first time, and again maximizing the benefits of neuroplasticity with high repetition. So essentially, you'd want to be working at high aerobic intensities to improve on whatever functional goals you have. Another benefit is that it reduces resting and working heart rate and blood pressure. And again, this has got to do with things like training the energy systems to improve your energy levels and ability to sustain high workloads for longer periods and without fatiguing easily. The next point is that it improves insulin sensitivity and body composition. And this helps control the amount of sugar in the blood and reduces the risk of developing obesity and diabetes. Lastly, it also reduces stress, anxiety, and depression, and to the same degree as medications like antidepressants in mild to moderate cases. And that would help in terms of improving self-esteem, confidence, and your perceived quality of life. Okay, so the next slide I want to talk to you guys about is the physical activity guidelines. So let's first look at the statistics. So only 17% of older Australians meet the physical activity guidelines, and 1/3 of adults aged 18 to 64 were insufficiently active. So we can find more information about our clients' physical activity levels by asking them how many days of the week are you active, and of those days, how many days do you participate in moderate to vigorous exercise? And then we can compare them to the guidelines recommended by the World Health Organization and work out what the limitations or barriers are for using the principle, particularly in a stroke population. So you can see the recommendation is how often is that we want to be working at 3 to 5 days per week, preferably every day. How hard is at a moderate to vigorous intensity? So a moderate intensity is we use the talk test. If we're not monitoring the heart rate, we use the talk test. So for someone that can work at an intensity but still maintain or hold a conversation would be what we consider a moderate intensity, and then vigorous is you're starting to get that huff and puffing, where you could only sustain that period for a certain amount of time, depending on your fitness levels. How long? We want to accumulate up to 30 to 60 minutes of moderate intensity exercise per day, or accumulate 150 minutes per week. Or if you are doing vigorous intensity exercise, it would accumulate up to 75 minutes per week. And the type of exercise would be any type of aerobic exercise involving large muscle groups. Okay, and then the next thing I wanted to highlight is that the guidelines are just a guide, and our role as exercise physiologists to recognise that the guidelines are there to set targets, but to also recognise that functional and cognitive limitations are a barrier to people within a stroke population, and therefore targets for physical activity needs to be created specifically for you, and we can determine that as EPs of what is considered work or physical activity for you. So we also have a role in progressively increasing physical activity levels when someone has adapted to a certain type of exercise or intensity, and increasing the challenge to allow for further improvements to occur. We also offer flexibility and creativity for people to increase physical activity levels, such as incidental exercise, like things like taking the stairs, standing instead of sitting for longer periods, and also maximising walking at longer distances. So the evidence for physical activity. So the effect size for engaging in regular physical activity and meeting the minimum requirements will help reduce the relative risk of any cardiovascular disease by 30 to 40%, which is a huge number just by meeting the minimum requirements of physical exercise. And the evidence for dosage, in that being 30 minutes of moderate intensity activity on 5 days per week, compared with no activity, was associated with a reduction in mortality risk of 19%. And then evidence for intensity is that higher intensity exercise is more beneficial than low intensity by up to 20%. So remember that higher intensities, again, the higher the dosage of the release of BDNF in the brain to promote neuroplastic changes. Okay. So I've just added this study by English et al. In 2018 that was published in the Stroke Journal, and they found that when stroke survivors stood up to 30 minutes, sorry, not 30 minutes, stood up every 30 minutes and performed 3 minutes of light intensity exercise. So things like mini squats, calf raises, or marching on the spot. They had a lower blood pressure over the day compared to sitting continuously for 8 hours. So the researchers found the same effect when walking for 3 minutes every 30 minutes. So most importantly, this benefit occurred even in people who were taking blood pressure lowering medications, which is an important finding because high blood pressure is a leading risk factor for stroke, and every small reduction in blood pressure reduces the risk. And then lastly, I just wanted to highlight putting the link and making the link all together. So the link between neurological disease and cardiovascular disease, when we look at any one of our patients, they either fall into a risk category because a cardiovascular event such as a stroke was the precursor to their neurological deficit, or their neurological condition will become the precursor of their development of secondary health conditions due to decline in function and lack of movement. So no matter what way you look at it, the challenge or our role as EPs is to get you moving and to maximise physical activity levels into your daily routine.